What I'd like to do today is tell you about a method of treating X-linked diseases using a method that we called X chromosome reactivation. So as you may know, the X chromosome has more than 1,000 genes that are subject to a process called X chromosome inactivation. So that leads to a shutdown of one X chromosome in the female to balance gene expression with males. So what this means is that the inactive X in women is a reservoir of healthy genes that we think we can leverage to treat various X-linked diseases. Now, there are at least 30 genes, or 30 X-linked diseases that affect both men and women. And so in the case of women, we think we can perhaps rescue those phenotypes by selectively reactivating the gene which is missing from the inactive X chromosome. And so what we envision here is a single drug that would treat these various diseases in a gene-specific manner, and that's very important, for a total market size in the United States alone of about 85,000 patients for a potential $10 billion blockbuster drug. And a quarter of that comes from a disorder called Rett syndrome, which turns out to be our lead program. So Rett syndrome is a serious unmet need. It is a severe neurodevelopmental disorder that's caused by mutations in a gene called MECP2. So the girls are born normal, but between 1 to 3 years of age, what happens is the girls begin to developmentally regress. They develop autism, seizures, and many of them never learn to walk or talk, and so it's extremely devastating. If they're properly cared for, the life expectancy is something like in the 30s. So unfortunately, there is currently no disease-specific treatment. However, there is hope that we may someday, very soon, be able to treat Rett syndrome, or perhaps even cure it, because it was shown many, many years ago by Adrian Bird that you can actually reverse the neurological deficits seen in Rett syndrome in a mouse model by giving back MECP2, a protein, to the brain. And so that was done genetically, and what we're trying to do now is to do exactly the same thing on a pharmacological basis, and you may have heard about these gene therapy trials that are currently in the clinic. Our approach is entirely different. So we have an epigenetic approach. We're also addressing the root cause, which is the absence of MECP2. But in this case, we're reactivating the native copy of, but silent copy of MECP2 from the inactive X chromosome. Believe we can do this selectively. And the key difference with gene therapy is that the method would be reversible. We don't need any foreign genetic material. We also don't need AAV, and there would be zero risk of overexpression of MECP2. So the way we do this is we target the master regulator of X inactivation, which is exist RNA. So it's a long non-coding RNA that is essential for establishing X inactivation, and it does so by coding the X chromosome and bringing silencing factors to it. So we design an antisense oligonucleotide directed specifically against exist to degrade it, and then to partially disrupt the maintenance of X inactivation. And then very importantly, without disturbing the unneeded genes on the X chromosome, we can rescue expression of only that missing gene, in this case, MECP2. So we learned that we can get a more robust response by priming with a one-time and low dose, so sub-oncology dose of a DNA methylation inhibitor called decitabine, which is, as you know, FDA approved and has also been used in children. And so to test this idea, we injected the antisense oligonucleotide gymnotically, so without a delivery vehicle, directly into the brain of a proprietary mouse model. And we observed a very rapid depletion of exist RNA, as you can see in this graph. So more than 99% of exist RNA is gone from the whole brain within 2 weeks. And then as a consequence, we have this very robust restoration of MECP2 protein after 5 weeks of injection. So here is an immunohistochemistry of brain sections from these treated animals. You see that in the wild type case, MECP2 is, of course, highly expressed from the brain sections. In the top right-hand corner, you can see the the untreated Rett syndrome animal with no MECP2. If we were to treat just with decitabine, also no restoration of MECP2 protein. If we treat just with the exist ASO, there's a partial restoration of the protein. You can see a few green spots. But when we combine the two treatments, we get this very robust reactivation of MECP2. So then we extracted the neurons from the brains, the treated brains, and we performed a Western blot analysis to see what was happening within the post-mitotic neurons. And we see from this Western blot that there was a near perfect restoration of MECP2 protein. Now here is where I need to emphasize that because we've done a proteomic analysis of the brain, that the reactivation for MECP2 is highly selective. So we're not seeing any significant upregulation of other proteins that are expressed from the X chromosome. That's what we mean by a selective X chromosome reactivation. Okay, so seeing is believing. So in this first video, you can see a peri-symptomatic Rett syndrome animal, and she looks more or less okay. If she's not treated, after 5 weeks, you can see her condition has deteriorated significantly, and she's become much less mobile. She's developed a repetitive disorder, and as well as a self-injurious behavior. And if she's further left untreated, she will very sadly pass away within a few days. If, on the other hand, she and her sister here are both treated with our cocktail, you can see that they exhibit absolutely no phenotype, no Rett syndrome phenotypes. They look completely normal. So on a single dose of our proposed therapeutic, you can see that in this Kaplan-Meier curve that there's a up to 4-fold improvement in lifespan, whereas the single treatments do not improve the phenotypes at all. We imagine that if we were to give booster shots along the way, that we could extend this curve further out, perhaps even to a normal lifespan. So we believe that there are some advantages to this ASO approach compared to gene therapy. So I mentioned there were 2 gene therapy trials that are in the clinic now. So Taysha has a mini MECP2 cassette that's controlled by microRNA to limit its expression. Neurogene has a full-length MECP2 gene that's also controlled by microRNAs, but even so, there's always the theoretical possibility to overexpress MECP2, which would unfortunately lead to a different type of seizure disorder. So both gene therapies, of course, require vector delivery, and as you know, AAV comes with the potential risk of immunotoxicity, and in the case of Neurogene, there was a recent setback where 1 out of 5 patients very sadly passed away from this AAV toxicity. Now, on a single dose in a preclinical model, you can see that the Neurogene data suggests an almost 3- to 4-fold increase in lifespan as well. But the key difference with our technology is that we have the option of going out even further to restore a normal life, perhaps to restore a normal lifespan. And as I noted previously, we can redose. In the case of gene therapies, of course, there would be no possibility of redosing their one-and-done treatments. So in summary, I don't think I need to go over the left-hand side. We're plotting a 2-year path to the clinic, identifying lead compound, completing IND-enabling studies, selecting follow-on indications, and we're actively seeking partners to develop the clinical candidate and to validate the technology in a pilot phase 1. So in summary, we have what we believe to be a one-size-fits-all technology that could potentially treat many different genetic diseases on the X chromosome for a total enterprise value of $10 billion. Thank you.